Hey guys, welcome to PHS Proud Audio Time once again. I'm very excited to share my interview today with Rear Admiral Scott Giberson, who is now recently retired. If you don't know Rear Admiral Giberson, then I don't know where you've been, but he is certainly a living legend for the Public Health Service Commission Corps. And I just want to provide you with a couple details on his background, just a couple minor details, just to let you know where he's coming from and the type of things that he's done. I've actually publicly stated that I think Rear Admiral Giberson has done more for the Commission Corps as a uniformed service than Surgeon General Thomas Perrin back in World War II, and I actually mean that. I wouldn't have said it if I didn't mean it. So just a brief history here of Rear Admiral Giberson and what he's done, and I have it written down here so that I don't forget anything, because it's very important to know. So Rear Admiral Giberson, if you're in the pharmacy world, he's a pharmacist by training. If you're an IHS and you've done the NCPS, the National Clinical Pharmacist Specialist, he's was part of developing the NCPS in pharmacy. He's a pharmacist clinician. He was the senior public health advisor for the Department of Defense in the Pacific Command. He was the chief professional officer for pharmacy and led the report that was submitted to the Surgeon General on advancing pharmacy practice. He traveled all throughout the country, all throughout the world to talk about advancing pharmacy practice. I know when I was in school, this was a big hot topic, and it still is, and he was very much behind that movement. He was the Commission Corps Headquarters Director, Acting Deputy Surgeon General, and of course the commander of the Ebola response in Liberia. Some of the awards that Rear Admiral Giberson has been awarded: he's received the Department of Defense Meritorious Service Medal. He's the reason, in collaboration with others, that the Public Health Service received its first presidential unit citation from President Obama for the Ebola response. He's received the Distinguished Service Medal for the Public Health Service, which is the highest medal in the Public Health Service. And he was named as one of the top 100 vets in the past 100 years by the Military Officers Association. So these are just some of the high points. He's done so much, and I really hope you enjoy this conversation with Rear Admiral Scott Giberson. Enjoy. So thanks so much, Scott, for joining me today. I will have introduced you formally in a recording that people can hear a little bit more in depth about what you've done. But for people in PHS or the military that haven't heard of you or anybody else, how about you just introduce yourself, give a little brief summary of what you've done and how you've ended up where you're at today.
Sure, Shauna. First of all, glad to be here with you and having a little chat. Right, it's a cool December night, and it's you know, when you think back about on a career, I retired at 28 years, about 27 years plus, and it was actually interesting to get the request from you just to do this, because when you have to reflect back on that many years, you forget about half the stuff you did, and you think too about how well it went in the beginning and the challenges you matriculated towards as you get older in your career. But I started out, you know, well, first, Rear Admiral Scott Giberson retired. It all started, I guess, in college when I was in pharmacy school. I had heard about a rotation for the Indian Health Service. Prior to that, I had, you know, considered serving in uniform. I was particular about the Navy, and especially being a Navy SEAL, which, you know, I laugh about now, but I still think in my mind I carry that personality, you know, a SEAL or something. But
I didn't know that. Okay.
Yeah. And then did a rotation out in Crown Point, New Mexico with the Indian Health Service at a pharmacy. Fell in love with the practice in the Indian Health Service of pharmacy, with the you know, sort of remote area, the fact that I could help American Indian Alaska Natives, and then to be in uniform, which, you know, is sort of our uniform and the khaki is the Navy adopted, right? So it's our uniform, but I can say
So I definitely want to touch on that, but I'll let you finish your intro, but I definitely want to circle back to that.
Yep. And then quickly, I spent the first third of my career doing Indian Health Service, combination of pharmacy, family practice, got into, sort of that expanded role in family medicine. Then through the leadership of the pharmacy realm, then I went into some global health, did some work overseas with Pacific Command, DoD, then got into leadership, did the CPO for pharmacy for PHS, which was a great gig. And then jumped into the real work with some of the real heavy load as an executive with the director of headquarters, deputy surgeon general, and so forth. Finished my career, what I call the sunset tour at CMS as an executive there, and retired this February.
It's definitely been a long road for you, and congrats on that retirement. And now you're president of AMI Expeditionary. So what is AMI Expeditionary, and how did you get into that?
That is correct. You always think about the network you have and the bridges you build during your career. And one of them was at Pacific Command. My director at the time, the director of the medical unit, was Dr. Tom Crabtree, and he was, brilliant plastic surgeon in the Army, colonel, did global health. We did global health together. We traveled all over the Asia Pacific together. He said, stay in touch. When I, was done with my tour down in Pacific Command, he went through the rest of his career, retired, I think 2007, 2008, somewhere in there. Started up with a different company, but sort of entrepreneurial in the healthcare sort of world, private sector. So healthcare solutions. Anyway, he progressed in his private, now new for-profit company. I progressed obviously in the core, and we always kept in touch. We met again face to face in Ebola in 2014 in Monrovia, which is fantastic to see him there. And then he said, "Hey, when you retire, give me a call, keep in touch." Yep. Well, we kept in touch throughout, and he was always asking. And so when I finally wanted to decide to retire, he said, "Yeah, I'll bring you on," and brought me on as an executive, part of the executive team, and for about the first 7 months or so. And then a couple of months ago, they appointed me as the president. So, I don't know how I went from retirement, where I thought I was going to be, scuba diving and golfing, to 70, 80-hour weeks now back again. So, but it's a little different. It's a little different. Yeah. It's a little less stressful, no matter what they say in my company now. It's very busy, a lot of hours of work, great mission. But in a way, we're a team, and we're, there's not the administration looking over your shoulder, or, all it's off, everybody counting on you to do things. And so, yeah, it's a good team. It's a little different, and it's a different stage of your career now,
Exactly. Yeah. You don't strike me as the kind of guy that's just going to sip margaritas on the beach for the rest of your life. I think you're going to keep pushing.
I say I'm going to, and I want to, but, that's a funny story though, Sean, because just the other night it was an extraordinarily busy week, and I think I put about 80 to 90 hours in the week, and seriously, because it was also including travel. And I think it was Sunday night when I started to finally wind down, and everything sort of stopped, shut off. I put a football game on, probably. My wonderful wife, who supported me forever, is sitting right next to me on the couch. And it took me exactly, she said, 13 minutes. And I said, I don't even know what to do. I'm kind of bored. And so, yeah, I don't know. She said, retirement's not going to work, honey. Yeah. And I said, yeah, I kind of figured that. But there's got to be a balance somewhere in there between, full bore, 80-hour weeks to just scuba diving and golfing. There's going to be an active retirement lifestyle somewhere in there.
Yeah, maybe with a little bit more time, but yeah, I think retirement's a little bit of a red herring that, you never really stop the need to feel contributing to something or valued for your work. And, most people that do just sit on the beach and sip margaritas end up dying early or are just super unhappy. So I think it's
purpose, right? It's having purpose. And it doesn't have to be something, like right now, we're still, in that for-profit world, you're making a salary and
Yep.
you're working hard and there's milestones and things. But you know, even when you don't have that, you should have purpose, right? You should be helping people, doing what you need to do, doing what you love to do, staying busy, staying active. Throughout my career, I always said, let me think, boy, this is drumming up a quote from long ago. I said, always be dynamic, never idle. And, you know, it sort of helped me throughout my career because you say yes to a lot of things and you get super busy and you say, why did I say yes to that? But it gives you so many different opportunities and experiences, good or bad. And I don't regret any of them because if I didn't like it, I learned from it. And if I liked it, then, you know, win-win.
Yep, exactly. I like that perspective. So I think we're going to have a lot in common. I think we do have a lot in common. You know, we're both pharmacists. We're both PHS veterans. I was only in for 5 years. I think both of our wives are from New Mexico. Is that true? Is your wife
correct.
from New Mexico? Okay.
Yep. I met her at my first duty station in Gallup, New Mexico.
Okay. So I have somewhat of an idea of your challenges that you have. So, but
and where is yours from?
So my wife is from the South Valley of Albuquerque.
Oh, sure.
And she's speaking of 80 to 90 hour work week. She's a general surgeon right now in her residency. So she's having fun with that. So
residents get no breaks.
Exactly.
Well, congrats on that. That's wonderful.
Yeah, thank you. And now we're living in La Crosse, Wisconsin. So just kind of moving all over the place.
Speaking of which, AMI is in La Crosse, Wisconsin. We own a lot of the vaccination and testing sites in Wisconsin. So.
Oh, wow. Good to know.
Mm-hmm.
Interesting. Okay. You know, just reviewing your, you know, having the luxury to look at your CV has just, you know, made me smile, honestly. And a lot of times just say like, hell yes, like, thank you. And I don't mean that, you know, you're very well known in the public health service, I think, but I think it's well deserved because of your track record and you really walk the walk. I remember when I got into PHS back in, you know, I did some co-steps back 2012. I came in as a resident 2015, but I remember, and I've always been big on public health service history. And that's why I have this thing called PHS Proud now, because I'm obsessed with it, even though I'm not active anymore. But I remember coming across your speech at the press conference with President Obama. And I know the Ebola thing is kind of the shiny thing and that everybody points at and says, oh, that was so cool, which, I mean, that put public health service on the map historically. And that'll be something we point back at that says, look at what public health service did. But I remember sharing that video of you giving that speech. I sent it to my dad right away because, you know, I was always proud of being a pharmacy officer, very proud to wear the uniform. So I remember that struck me because I was like, this guy is like, this is what I think PHS should be all the time. And I think a lot of us know on the ground, we don't always have what the Monrovia Medical Unit represented for a lot of people, which was more, you know, structure, camaraderie, really coming together for a single mission. And I think that can be lacking in the commission corps a lot. But I just remember sharing that because I was just, you know, I was PHS proud with that moment and just like, gosh, like this is what the public health service is about. So that's what I'm about with PHS Proud. And I really want to highlight stories like yours. Obviously, you're a living legend in the public health service. And it would be, I mean, we need to document and describe these things. And I think my hope is in some small way, maybe we can see what has been done by leaders like yourself to see where PHS needs to go. Because I think a lot of us know it's underutilized, it's not known, and there's just so much more that PHS could be doing. So I just kind of provide that preamble to just, again, very grateful to be able to speak with you, and I just respect a lot of what you've done as a uniformed service member, as an officer. So thank you.
Well, Sean, that honestly, that means a lot, more than you know. You know, you get into this world of work and you forget about the things that matter the most. And it's not the accolades, it's not the events, it's the people you meet and the stories you can tell. And so hearing that story of your experience means more to me than the awards you get or the titles you had or whatever. So if you are put in a position to have the opportunity to have an impression on a person like you, then that is more reward to me than anything else, right? It's that, I guess you'd call it legacy or lasting impact or inspiration, whatever it is. So but thanks for being PHS proud. And I didn't really know the story behind it, and I almost suspected it was either at first, before I knew who was running it, if it was a retired officer that had a full career or but it's even more impressive the fact that you were in for a shorter amount of time and you still felt that. So that's awesome.
Yeah, definitely. In some ways it's a curse because in some ways PHS grad being, it's just something that I'm very passionate about. So, and just spreading the word on. So, you gave a nice potted intro of your career, and I just want to go down memory lane a little bit more and just kind of highlight some of your experiences as an officer and highlight how the culture within PHS has changed over time. And I think you have had a lot to do with that. I said on a LinkedIn post that you were aware of that. I think you've done more for PHS as a uniformed service since Surgeon General Thomas Perrin. I actually mean that. And I think if anybody can see your track record and appreciate, again, just the service for the Corps, I think it's a hard debate. So you mentioned you started your Corps career in Gallup. Was that a co-step or was that your APPE rotation?
Yep, that was just a rotation. It was to be honest, it was probably the farthest rotation away geographically from Temple, where I went to pharmacy school.
And that's in Pennsylvania, right?
It's in Philadelphia, Pennsylvania, right? So it was almost East Coast to the far Southwest. And I think I, mostly stayed on the East Coast in most of my life, family in different states, but not really traveled that far west. And, fell in love with the beauty, the landscape, just the type of work. But yeah, I started as an extern, or not intern, I would just say, in my last year of pharmacy school.
Okay. And so at that moment, had you heard about PHS? If not, how did you come across it?
I probably heard about it from a recruiter at some point, but it was more about just a rotation where I could do a little bit more progressive pharmacy practice, and I was sort of into that. I was at the University of Scranton for undergrad before I went to pharmacy school, and I was in a pre-med, and I actually wanted to be a physician at first, and I had a sort of a event in my life where my father passed away when I was 17. He was 44, and so since that was a sudden event, it really changed the trajectory of my life completely. And so I needed to recoup. Anyway, decided that I wanted to. Actually, back in you can't really even recall back in the day. There was no internet, and you didn't know too much about a lot of different things. And if I think I knew the full spectrum of healthcare and healthcare professionals, I don't know which way I might have gone, but I might have still stayed as a physician because there's so many things you can do. But
for sure,
I felt the next best clinical thing I could do, aside from being a nurse, which I really didn't want to pursue, that was to be a pharmacist. So I went from pre-med Scranton after 4 years to pharmacy school. Yep. And then of course, Indian Health Service.
Okay. That's interesting about your father. So I was, it just brings up something that I was discussing with some new friends of mine. I was in this entrepreneur boot camp for veterans, and there's a lot of, military guys in there that have done crazy things. And we talk a lot about adversity creating strength and prosperity creating weakness. And I'm just, hearing something like that with your father is like, that would be super tough, I would imagine. And then I also think in that vein, wow, was that something that that could have just been a huge strength for you, having that tragic event that I just believe people have those events happen, and you can really, depending on how you deal with it, I mean, it can go really bad, but that can really be a strength for you. Do you feel like that was something that has been something for you throughout your career?
100%, Sean, 100%. 110%. I mean, but I, you know, what it is, it's an infusion of this incredible emotion and energy, and it can go either way, right? So, you know, if I introduced you to some of the freshmen that I was with at the University of Scranton my first year out of high school, and so my dad passed away in September, so it was my first semester, my freshman year of college, and if I introduced you to some of those folks, they would say, well, I thought he would die by the time he was a senior. And then meaning me, because I was a little bit, you know, a little bit maverick, a little bit wild. And I needed that. That was my coping mechanism, right? Just pretty mischievous. And I was in the dean's office a lot, the dean of students. And they probably would never have thought I would have been successful, although they saw some, you know, brilliance somewhere in there in the skull. You know, I was too busy causing trouble and doing some things I shouldn't have been doing. But yeah, it's that same energy and emotion. Then as it matures and it translates into drive and passion, you know, in the positive side. And it's amazing how close that will teeter back and forth, you know, until you truly mature. And, you know, I was only 17 or 18 at the time. So I was 17 at the time. So, yeah, I mean, if you use it correctly and funnel it the right way, then it can be a huge facilitator to, you know, success and energy and things like that. So, yeah, picking up on that is correct.
Yeah, no, I can't imagine. So, yeah, thanks for sharing that.
Yeah, no, it's been a driver, and it was a negative, it was a tragic thing, but I've used it in every possible way to be positive about, you know, if that never happened, maybe I would have never, ever, you know, was able to accomplish what I did. And so
exactly. So what was the culture of pharmacy when you were going to school? Because like when I was going through 2011, 2015, you know, it was all about medication therapy management, pharmaceutical care, making sure that we're, you know, practicing at the top of our licenses. How was what was the expectation for the pharmacist when you were going to school?
So when did you go through, Sean?
2011 to 2015, I was at the University of Minnesota.
Okay, great. Yeah, by the way, I spoke to them. I think I did one of their, I think
Melindy
I did when
lecture.
I graduated, or commencement, I think. I did University of Minnesota Duluth commencement, and I also did University of Minnesota commencement, but I can't remember what year it was now.
Yeah, you spoke at one of my classes in 2012, something like that. That was, I think that was a Melindy lecture for.
Melindy lecture, right? Yeah. Great. Yeah, that was fantastic. Little tour of lectures all around different things. But let me go back to your question. You know, when I was coming through pharmacy school, you had your choice. You know, you did retail pharmacy or you did hospital pharmacy, or you could do this unusual, crazy thing. You know, that was you know, more expanded scope pharmaceutical care, and it was really, I don't know if it was isolated to Indian Health Service, but it was certainly widely known as the most innovative, progressive, and that was back in, well, 1990 or so, you know. But anyway, then when you get into that world, the Indian Health Service, you realize that even that was 20 years removed from when it really started in the 70s. And, you know, we'll talk a little bit more about pharmacy in the future, you know, in the next sets of questions. But, you know, it's amazing some of the things I was able to do in the early 90s that, you know, even today would be progressive. So, you know, in a way, we take two steps forward, one step back sometimes with pharmacy. And I have a lot to say about pharmacy, but in general, it was great to be able to get out from that sort of rubric of you get inpatient or you get, you know, retail. There's also you could be a drug salesman, right? Right, because that's when they used to actually employ pharmacists to do selling, you know.
I didn't know that.
Yeah, amazing, huh? You actually use a pharmacist instead.
But
that never took off for me. I probably wasn't good looking enough, you know, to be in the pharmaceutical sales world back in the day. But
we'll never know.
Yeah. So, but anyway, it was there weren't too many choices. You did sales, you did retail, you did inpatient, and that was pretty much it I can remember. Or academia, right? You go back and teach. So yeah.
So you graduated and then you went straight into the commission corps. And was it just at that time? So describe a little bit like how you got in? Was it just applying and you were good to go and they put you somewhere? Did you have to choose? How did it work then?
Even back then we had trouble onboarding some folks, it takes a long time to get commissioned, and maybe not as long as it does now. I don't quite remember, but what I did was I knew that I wanted to go back out to the Southwest. And I was waiting for an opening there. And in the meantime, I took a job in Philadelphia at PACOM, Philadelphia College of Osteopathic Medicine Hospital. So I was working inpatient, doing TPNs and IVs and stuff like that for inpatient, some pharmacokinetic calculations. That was the big clinical thing I was doing.
Yeah, some gentamicin dosing.
Yeah, some gentamicin dosing. And just waiting to get commissioned. And once I got the call that I would get commissioned, I'd be able to go out to Gallup for a job. Then I took, I jumped on it and headed out there. And that was the beginning of the career.
So at that time, was there BOTC at the time? What type of training did you get as an officer going in?
I got, welcome to the Commissioned Corps. You're going to be an officer. Get this uniform,
Yep.
I guess I got some handbook of some sort. I might have had a phone call because obviously there's no video or anything like that. So
yeah.
I think I had a phone call with headquarters, PCP maybe at the time it was called, about what to do. And then you just follow the lead of the people who are already there in your site, right? So in Gallup, we had, a number, it's a big outpatient center. So we had a number of captains who were there, Gary Erickson, Bob Parrish, all the ones that most folks don't even remember, but they were my mentors, and they're mentors because you emulate what they're doing and, follow the handbook as best you can. And that's that. But, you didn't really feel the camaraderie of uniform service. You just sort of were in uniform,
Mm-hmm. So that brings up the next question, because I know when I got in 2015, I remember I was at the Albuquerque IHS, and I remember they would be talking about like, oh yeah, just a couple of years ago, we only had to wear the uniform on Wednesdays. So was that the situation when you got in, or what was this? What was the uniform situation?
Then yes and no. So yes, it was, but you could wear it more often, right? So, sometimes we chose to wear it every day of the week and people thought we were crazy, right?
Yeah.
So, but if you were into that and you liked the uniform, which we did, and we were into the service and stuff, you'd do it. But you didn't, but it was unusual because you didn't understand really what it meant to, and I was just as ignorant as the next person coming in and not really understanding what it was like. You don't go to boot camp, you don't go to, OCS, officer candidate school. So you get thrown in, and then you get out in this situation where like I said, you follow the lead. So it's hard to have original thought sometimes about it because you don't understand it, and until you mature to that point where you do understand it, you make just better decisions, right? So it was the Wednesday wear, and it's embarrassing to think about that, but it was like that. It's the way it was, right? It's like
exactly. So that's, I think those things, they're an unfortunate wart or blemish, but in some ways I think it's important just to acknowledge those things and say, this is how it was. And I think it's better to talk about it, because then you can understand, because like young guys like me coming in, you were at my OBC 81, and it's like and I loved it, like, because again, you understand the power of the uniform, the purpose behind it. And then when you get out in the field and then you see older guys like not wearing it correctly, or, just looking disheveled, and, you really have an eye for those things. At least I did. I think it's helpful to understand, like, they didn't get OBC for 2 weeks. They didn't, I think 2006 was when it was mandated, where it was OBC started, I think. So anyway, I think it's helpful just to understand, so you don't like get too pissed off at people.
OBC and the evolution of that to the point where it was the full 2 week kind of a thing, and was probably one of the biggest transformative things that PHS ever did. And I wasn't at the very beginning of it, but I came in at about OBC 30 and went from OBC 30 to OBC 110 or something like that. I can't remember, but and then before me, I don't know if you remember Captain Dan Beck, who
engineer.
heavy player in headquarters, but also in he was at headquarters for forever, and in all different roles under John Babb when it was the Commission Corps Readiness Force, CCRF, before 9/11, in the late 1990s. And so anyway, that evolution of the Corps from 9/11 forward is really like I said, transformative and transformational. So
absolutely, yeah, very critical. And again, it's not even that long ago. So
for me, it feels like it was 4 decades ago. But but I remember the feelings, and it's very all those senses of even are palpable, right? Just the smells, the setting, the people, the emotion, all those things are so close to me right now. It's hard because I haven't really talked about it much since that point in time, and this is a great, I was really looking forward to this because of that, to dig a little bit deeper and remember some of those things that I don't get the chance to do.
Yep. Good. I'm glad to hear that. It makes me feel good. So, while we're on the topic of uniforms, so I know you said before that, so PHS had the khakis before the Navy. I read an article when I was doing some research last night, and I had you quoted saying the same thing. So what's the history and story with the khakis? Because I have a bunch of Navy buddies that I'm sure if I told them this, they would, pull their hair out and wouldn't believe it.
Oh, so, I might not get this history exactly right, but part of that sort of quarantine time frame when we were, quarantine officers and such, and communicable disease at the ports, when we were, really taking care of seamen and sailors coming in, maritime, era. I'm assuming that was one of our first, if not the first sort of uniform we had, was the all khaki uniform. And how and why the Navy adopted it, I'm not too sure of that history, but somebody will know that one. But yeah, it's always good to rub it in. I mean, we get much like the Air Force, we get harassed sometimes as a uniform service. We're not the smallest anymore by far. NOAA, and I don't know if the Space Force is a part of that now, allowed to be harassed with us too, because it's a little bit smaller. But we're especially in the last 15 years, but I'd say 20 years, a very, very well-known, less secret service for what we can do and what we have done since 9/11. So, that is probably the most prideful thing we should have as a service, to know that. As a matter of fact, I'm kind of tangentially speaking here because we're going all over the board, but I get to spend a lot of time now with retired 1 stars, 2 stars, 3 stars, even sometimes, all the services. And I often, when I introduce myself and what type of a 2-star or what my service was, and they say, oh man, and this is just last Monday, I think, 2-star Air Force, former Air Force Admiral, retired, said, boy, if there was ever doubt of what you guys were capable of, you certainly have proven yourselves in the last decade. And he knew about Ebola, and he knew about, now, of course, a lot to do with COVID, but SARS and all the different things that we've been involved with. And then this is from a, line side, not a medical guy, line side 2-star Air Force general. Yep. So, that certainly warmed my heart there for a bit. And I said, well, thanks, that's what you want to hear, right? It wasn't, when I started in the early, or the 90s, early 90s, you would not get that same story from a general or an admiral in one of the armed forces, right? So really, really proud over those 2 decades for that.
Yeah, no, that's really good to hear. And when I always talk about the service that I was a part of, I always say, I was part of this lesser known service. Most people haven't heard about it. And then, but there are some military guys that will say, oh no, we know about you guys. And yeah, it's just always like, oh, it makes you feel really good and, respected and, again, valued. So,
well, I mean, think about all the public health issues that have happened in the last 2 decades. I mean, maybe it's because they've always existed, but because of the freeway of communication now, everybody knows everything everywhere. You know, it's allowed us to be more visible, and because so many more issues are public health related, whether it's disaster, public health like post-hurricane, post-flood, or whether it's infectious disease, communicable disease, you know, whether it's research, you know, we're all over, and we can be all over, small but mighty, right?
Yep.
So I always think we're like the movie 300, you know, we're fighting against the thousands and millions of people, and there's 300 of them.
Exactly. Yep.
But mighty, right? We carry a big stick when it comes to expertise and
I agree.
And you know, just the depth and breadth of public health and medical expertise.
Exactly. And we get that stuff from places like IHS that, again, are forgotten government agencies. Nobody thinks about American Indians and Alaska Natives in the United States, unfortunately. So I think those going through the trenches in the dirt like that, again, just adversity. And I think people see that.
Think about how the Indian Health Service catapulted the profession over the last 4 decades, 5 decades. Pharmacy would not be where it's at if it wasn't for the Indian Health Service. I mean, you know, even people that wrote textbooks that you studied from that you know, called the things whatever they called them, that coined the phrase pharmaceutical care, that all prior to all that was Indian Health Service. You know, as a matter of fact, I can't remember, but you know, some of the main authors of some of those pharmacotherapeutics books that we all had forever in pharmacy school were written by one of them former IHS pharmacists. So yeah, it's
and they were core pharmacists, weren't they? Wasn't was Dick Church one of them that started the?
Oh yeah, Dick Church, but even before Hepler and Strand wrote one of the books, and I don't know if Hepler and Strand coined pharmaceutical care, but it was based off of the work of the IHS 5 standards of pharmacy practice, which you know, have been the gold standard from the 70s, even before then, 50s, 60s. So that's when you really know your true history, when you think about an entire healthcare professional in the United States was driven by this little known government entity called the Indian Health Service.
Fascinating. I think that's a good segue to describe your impact on clinical pharmacy through IHS. So you started with IHS in 1993. You were there for 10 years before you transferred. And so if you're an IHS, you know about something called NCPS, which is, forgive me if I get it wrong, National Certified Pharmacotherapy Specialist.
National Clinical Pharmacy Specialist.
Okay. Yep. So you were part of the group that started that. So what's the story behind NCPS and how did you get involved with that?
Yeah. Well, always learning from your mentors. You know, we were never the first. The first was IHS pharmacy practitioners, PPs, right, in the 70s. And that was the Dick Churches of the world, right? And even prior to him, and some of his folks that he worked with, you know, and forgetting some of their names at the moment, but they were the originals, right? They were the originals, the OGs. Yep. And there's not many of them, right? But they were able to do diagnostics and, you know, the just about full, you know, expanded scope, even beyond probably what you'd think is expanded scope, because you're doing it in rural areas where there's not a lot of care at all. So it's either that care or you know, really no choices. So it worked perfectly, you know, and it was the elegance of expanding the scope of a person that could do it, that was highly trained to do it. And you know, they took a little extra training and they were able to do it. And so that was an offshoot of that. It kind of died a little bit in the 80s, and we wanted to reinvigorate it in the 90s and moving forward. And so a group of us out in Albuquerque, we met in Albuquerque, I believe, and we had some folks from Santa Fe and from New Mexico, other places in New Mexico and Phoenix. And I think 5 or 6 of us got together and sort of put this concept together to reinvigorate with a little bit more of the standards of the time in the 90s. And I can't remember exactly what made us formulate it that way, but it was for folks that wanted to get credentialed and privileged within the Indian Health Service to practice in Indian Health Service facilities only, because that's how we could credential it a little bit easier without, any legal issues, and expand our scope. And then we, that was the 90s, but we also took it to the next level by licensure in the state of New Mexico, and only in New Mexico, but licensed pharmacist clinician, which was really like more like a PA-ish, because I was able to practice in family medicine. So I did that for 5 years, and that was completely outside the pharmacy realm. I was basically mid-level, right? So I was privileged in not chronic disease management, meaning therapy, but I would write the prescriptions just like a primary care provider. And I would see the patient full head to toe, could do diagnostics, could do laboratory, can do anything. It was just another healthcare provider in family medicine. It's just that my base discipline was pharmacy instead of nursing or a PA, right? So, and I remember working with the chief of family medicine in Gallup, and she told me, I see nurses that go from nursing to BSN to nurse practitioners, and then I see now this first cohort of pharmacists that went back to school at the University of New Mexico with nurse practitioner, curriculum, and came out as this pharmacist clinician. And she said that was very easy to work with them, because it's pretty easy to teach a clinical person that physical assessment and diagnostic, because it honestly doesn't change that much if you think about it, right? Doing physical assessment in the 1920s is pretty much like physical assessment in the 2010, right? So and diagnostics doesn't change that much. Some of the level, if you get guidelines like JNC 6 or 7 or 8, whatever, and it's different. But what changes the most and what's the most dynamic is the pharmaceuticals and the therapy. So having that base first makes it very easy to teach and become clinical to primary care provider. Anyway, I distinctly remember her telling me that a lot. And so, and as of right now, there's a current pharmacist out there, and still in Gallup since probably probably even maybe before 2000, maybe 1997 or 8, he came in, and he's still a clinician out there in family medicine, doesn't go in the pharmacy at all. And he's been doing it for a couple decades. So,
oh, wow. Is that Ray Brand?
Oh, Nate Yale.
Okay. I haven't met him. Okay.
Captain, well, he was with me the whole time we were there, and then I left and he stayed. And every time I go visit, I said, I should have stayed. So he goes, come on, Scott. He goes, you should have stayed. You get to see patients every day, and you don't have to work 80 hours. And he goes, he doesn't have any inpatient responsibility. So he's just a sort of a fully privileged, and boy, he's brilliant. I mean, he knows everything there is to know about chronic disease and disease management. And that's what it mostly is, right? You make the diagnosis pretty much once, and then you can re-diagnose or reassess and then make a new diagnosis. But for the most part, it's chronic disease management, right? Unless you're taking care of trauma or something. So,
So for the pharmacist clinician licensure, was that already in place, or were you part of that initial?
It started in the state, but they hadn't had, and the reason it started was because a former IHS pharmacist was on the board at the state board in New Mexico. And she, got it started with their board. And then the first 2 Indian Health Service pharmacists to do the pharmacist clinician licensure were myself and Randy Burden. Randy Burden was from Santa Fe. He was a cardiovascular specialist in Santa Fe. And I have license number like 000018 of the pharmacist clinician licensure. But I think 02 of IHS, because 01 was Randy. So
wow.
Yeah, it's a good history. It makes me sound really old, but but once again, recognizing we were we were preceded by the Eternals, the OGs, the ones in the 70s were doing pharmacy practitioner work, but there was no state licensure at the time.
Interesting. So I did the pharmacist clinician course. I did, I got my license. I didn't practice to the extent that you did. And, kind of got to see the challenges with implementing that. Even in an IHS, I think there was some confusion as to, okay, is the PHC the pharmacist clinician, are they seeing patients only? Are they, being a PA or NP, or are they also helping with other pharmacy related things, medication requests, med rec, stuff like that. So there was sometimes some confusion or misunderstanding on that role. But so it's a very advanced role. I'm sure I didn't know about it, honestly. The New Mexico clinician coming up at the University of Minnesota, I think maybe we were too full of ourselves that we didn't want to listen to anybody else and what they're doing. But when I went to New Mexico, I was like, wow, this is really cool. There's a pharmacist clinician. This is what I'm all about. I ended up changing kind of my perception on what a pharmacist's strengths or what I felt best at. But so it's been a long time, with the pharmacist clinician in place. It seems from my perspective to have stagnated.
Yeah.
But so I'm just curious, like there's a lot of stuff going on with, with the pharmacy profession changing. So I'm just curious, like from your perspective, like where do we need to go? Should it be pharmacist clinician? Like, how do you see, because you've done so much in pharmacy, like I got to know.
I mean, that's a tough call. So we were trying to push the boundaries of pharmacy. We weren't trying to replace the pharmacist. As a matter of fact,
okay,
at the time, given the years of schooling you have to go through to be, now a PharmD, and given the training that you could have while in school, we absolutely should be able to do so much more than we do now. Pharmacy, and I don't mean this in any derogatory manner, but sort of has to move at a glacial pace because we're smaller. We don't have the advocacy or lobbying power that physicians or nurses do. And so although we have the training, obviously we have the talent in the profession, we were unable to really, move forward like we should have. And if you think about it, this is a fascinating, sort of analogy when you think about, for decades, we argued the fact, outside of IHS, because in IHS it was being done, but we go through 5-6 years of schooling, sometimes more if you had an undergraduate degree, and then you went to pharmacy school, 7 years, 8 years.
Yep.
And we had to argue if we could give an immunization. Okay. Nobody, you guys can't do it. First of all, LPNs were doing it, right? Paramedics, EMTs, whatever, giving shots, doing all kinds of stuff. And a pharmacist, after that many years of schooling, couldn't do it because obviously we can't lobby correctly and we don't have enough. It has nothing to do with skills, talent, education, curriculum, whatever. Although we weren't teaching it necessarily up in every place in pharmacy, but so think this through now. So fast forward to COVID. Within a split second of an emergency, you got pharmacy techs giving immunizations without a question, right? And so all that stuff we argued was a given that, of course, pharmacists give immunizations. Not only did we give them, but if it weren't for us, the COVID response would never be where it was or where it is now. And so, so it just goes to show you some of the archaic thinking back 20, 30 years from now. It could have and should have been fast forwarded to this point. And it's not just with immunizations. That was just one example, but think about this.
Sure.
What made what was the value that the pharmacists brought to the table with COVID vaccinations and testing? It was the fact that they were everywhere and they were highly trained and they could access to the public, access to healthcare. Same concept. We're archaic in our thinking that we can't do chronic disease management or medication therapy management or whatever you want to call it. The fact is that people go see their doctor once a month, once a year, or once a quarter, whatever. Sometimes they miss appointments, doesn't matter. They always come to the pharmacy for their medication, right? Well, we hope they do, but most of them do, right? So they go see, a pharmacist every 30 days. They go see their physician once or twice a year, if they're just chronically damaged. That access is undervalued, underutilized. It's archaic to think that we can't do the jobs that, it doesn't take death across everywhere to say, let's just utilize the pharmacists because they're everywhere. Same argument for public health in general, or healthcare in general, or preventive health. The U.S. healthcare system costs, per capita so much money, and the outcomes, they're sort of okay compared to globally. They're not good compared to how much money we put into it. It's not good at all. Think about if we did preventive health or any kind of things like that out of pharmacy worldwide or U.S. wide. So, it's where do I think pharmacy needs to go? Well, I mean, I probably should have done a follow-up to the Surgeon General's report 5 years after we did it, because we really had a lot of momentum. When I think I started it, and it was there was 4 states that, I think 4 Medicaid programs that recognize pharmacists as providers. 4 years later, there was 32 states that recognized pharmacists as providers. So, I mean, that's just that was another one of those things that, you know, I wish I had more time in one day to do both jobs that I could do. At the time, I, you know, sort of matriculated up to the DSG acting role, and I was obviously too busy with all these other things at Ebola. But that was the time when, you know, pharmacy, we were right on the cusp of really blowing it up, and we had a lot of support. We had a lot of support from other professions. As part of the Surgeon General's that report, and I know it was in some of the questions that you preempted with, we had letters of support from major organizations. I even had a draft, which I still have in my folder, a draft support letter from the AMA. And it was unfortunately, she supported us, and she was going to write this letter that we could send to Congress with the other letters to say pharmacists should be, you know, federally recognized providers. And that was the big hurdle, the AMA at the time, right? And then her time was up as the lead of AMA, and the replacement happened to be a little bit more old school. It's the most diplomatic way to put it, right? So we regressed after that with AMA's relationship, and I was not CPO anymore, and it was on and on. So it's an interesting history.
Yeah, it's all timing in some ways. So that was huge. Again, when I was in pharmacy school, this was all the rave, so to speak. The Surgeon General, the report to the Surgeon General on advancing pharmacy practice. Somebody's calling me, so I'm just going to decline that. So, you know, it was a huge deal. You were going around the entire country, internationally, speaking about this. And so, you know, I was kind of thinking in preparing for this, what you noticed across the country, how pharmacists are as a personality or just as a group. You know, schools can be different, and, you know, obviously their rankings and stuff, and culturally and stuff like that. But what did you notice about the different, or the similarities, excuse me, in how we really are as a profession? And you know, did anything jump out?
Great question.
Yeah,
great question. I'll give you through two lenses. One, as the CPO, when I was traveling around doing all the public speaking and sort of advocating for the change in pharmacy in the profession. That was one lens. The other lens is as the I think director of headquarters / DSG at one point, having the ability, and I'll give you that one too, of oversight of all the boards that we'd have to do for promotion, right? So, you know, PHS has 12 disciplines per se. Every board or every group, pharmacists, nurses, physicians, therapists, they all go in their board, and their board is made up of all their peers, except that the DSG or the acting DSG can sit in on all those boards and chair the board, right? So, okay. But then you get to see the personalities and the way it's a very distinct, difference in between how they run their boards and how they, their behavior in the boards, according to mostly like their professional, way to do it, so. Yep. And I won't comment about the other professions, but pharmacists have a lot of rigor behind what they do. They like the organization. They like the data inputs. They have to cover themselves. They're very careful about CYA. Yeah. So they do all the numbers and they get all the things, and they'll argue about 2 decimal places, and it's a tough battle to get promoted when everybody's check the boxes. They're a very passionate group to do that, right? So that the core pharmacist is that driven, passionate, meticulous, and I won't say any of our negatives, but that's our positives, right? That's all of our, that real, they support one another, which is another great thing. Huge difference. And I'll give the pharmacists in the core props, because we always say we're the best category, but we support each other to no end, and you don't always see that amongst the other categories, right? And so it's always the esprit de corps comes a lot from our category, right? Yeah. So going outside that, the lens of the CPO traveling across country, private sector pharmacy, it's similar. pharmacists definitely have a lot of passion. They're meticulous. I would say then you get into the a little bit more almost too humble. Okay, so they don't have the confidence, or maybe it's the training that doesn't give them the confidence to be, hey, look, when you graduate as a physician or a PA, a nurse practitioner, a provider, you have a certain aura about you that I'm capable, I'm doing this, this is my scope. Because pharmacists don't have that defined scope, and we're always trying to like gain that respect from other people. You come in sometimes too humble almost to the profession, right? And you can't, it's hard to advocate for yourself sometimes. It's good to be humble. It's a very, we're taught in pharmacy school the characteristics that you need to become a good leader. You're collaborative, you have humility, you communicate well, you're a diplomat because you have to convince the physician that it was their idea to change it, right? So you have to
exactly.
do that. All those kinds of traits make you a phenomenal, give you the ability to be a great leader. I don't know if you take that up on that, but
yep.
I always used to have every OBC. I would take the pharmacist aside, and I hope I did it here, but I try to get the pharmacists together afterwards and say, and this isn't about pharmacy, but you asked about the pharmacies specifically, and I say in the real world, you fall into a sort of healthcare model where the physician is sort of the decision maker in most cases, most situations. But here in the core, you're an officer and you have great leadership skills, so you should utilize them. And you're not in this rubric where you have to listen to, a specific discipline or anything. You're multidisciplinary, and so you need to lead. So
yep.
Always something that they appreciated and moving forward. So anyway, so that's where pharmacy is, and that's the two sort of things I saw that what held us back a little bit moving forward as a profession. That humility, and that's not a bad thing, but it did make us move at a little slower pace than others.
Yeah, that makes a lot of sense. You're definitely, I think you come off as a very humble person, and again, unassuming.
I come off as that, Sean, but I'm not really, right? I'm very outspoken.
Yeah, I mean, I've seen you in that situation again. So yeah, it's a double-edged sword, so to speak, there.
Yeah.
Well, okay, so I kind of want to bring it back. So this was kind of like when you went to IHS, you really were developing your pharmacy skills. You were spearheading a lot of these efforts to have pharmacists be providers. And then you also, that led eventually again to this very important report when you were the chief pharmacy officer. But before that, and this is kind of what to your point of what you're just talking about in that kind of getting outside of just the pharmacist identity, you then did what I think a lot of people don't do. You were at IHS for 10 or so years, and then you went with Pacific Command and the Department of Defense. And again, this is starting to see like, oh, wow, like, okay, so here's an officer that is really embracing what it means to move around, to go where you're needed, take opportunities that come up. It really hurt me when I would see pharmacists just stay in one spot, and they would be expecting to get 05, or they would have a sense of entitlement in some ways of they should be getting a certain type of promotion, when again, compared to somebody like you, they haven't met that level of officership. This is just one step in that direction from my vantage point, because now you're going with the armed forces. So how did that opportunity arise, and why did you decide to, because this is like a huge catapult from my perspective for you. So how did that come up, and why did you choose to go that route?
Yeah, greatest move I ever made in my career. I mean, honestly, that was the change. That was the game changer for me, to jump outside that box, right, and to see outside what it was like. Obviously, loved the uniform. Passionate about the service. Wanted to, probably wanted to be with DoD at some point, or transfer in, or inter service transfer. But I'll tell you how it happened. Really unusual. And I said, the network you have is so powerful. I talked about Dr. Crabtree, Tom Crabtree, my colleague. He got me into AMI, and I met at Pacific Command. But to get into Pacific Command, so I did Anthrax response at 10/11/2001, right? Not 9/11, 10/11.
Okay. It
was with John Babb, Admiral Babb at the time. I was probably a 04. I think I was in 04. And went to New York City, Morgan Station Post Office, Anthrax, postal workers, crazy. It was insane. There was more stress about Anthrax than there was about 9/11 after, if you actually look at documentaries, and it was more stressful because it was the unknown, right? What's next? Smallpox, Anthrax, bioterrorism, all that stuff. Crazy time. So I guess I did pretty good with Admiral Babb. I was on his team. He was the lead. It was a pretty sensitive situation. I worked with the postal workers and some other of my colleagues now who went on to do some great things. And Rob Tasato, I remember, Captain Tasato, Admiral. Anyway, worked it. After that, the Surgeon General Carmona came in and he asked each of his admirals, hey, give me the names of a couple people. I'm looking for a top flight person to go out to Pacific Command and represent the Corps at the Armed Forces. And we didn't really have stuff like that before, right? So,
yeah.
We had a PHS officer out there, Captain Kathleen Downs at the time, and she was doing a great job at Pacific Command, and they wanted to I think she was heading out for another tour, and they wanted backfill. So I had an interview with Admiral Carmona, and I guess a few other folks had interviews, whoever the other admirals recommended, multidisciplinary, obviously. And I went from the chief pharmacist of Duluth, Minnesota, to senior public health advisor at Pacific Command. And I thought, holy cow. I remember now, think about it, northern Minnesota, Duluth.
Yep.
0 degrees for the entire month of January, right? And I came home to my wife and I said, Lynette, what do you think about going to Hawaii? And she's like, oh my goodness. So we had just had my son. So my son was born on Veterans Day, 11/11/01. So there was 9/11, 10/11, and then 11/11 when he was born. And so we took him, picked up, and took off the next summer. So we were out in Pacific Command in Hawaii, and it was the start of a unique and different career,
to say the least. So what was your experience like with the military? And you were Greenside, right? Like you were with the Marines and
the Army. Yeah, mainly
okay.
Army, but it was we were at Camp Smith in Pacific Command, and it was sort of the medical side and disaster response, humanitarian assistance. They had a direct report organization called the Center of Excellence for Disaster Management and Humanitarian Assistance. And Colonel Crabtree at the time, or I think he was probably a light colonel at the time, is the medical director, and he had a staff, and I was on his team. And well, I loved it. I mean, obviously I had some amazing people around me. He was, like I said, such a highly regarded plastic surgeon, worked Operation Smile. I had a former flight surgeon for Air Force One, who was my other colleague, Air Force Major at the time, Major Zodu. We all became good friends, still good friends. Just being able to travel with them and learn it gives you that esprit de corps feeling a lot differently than ours. And I think that probably, educated me to the point where, I said, if I'm in a leadership role, I'm gonna change the way think and feel and act, and if I can. And so that was the start of it. And we got to travel around and do some good things for HIV/AIDS. We did the PEPFAR program, President's Emergency Plan for HIV/AIDS, and it got me into another realm of global health. Yep. Finished my MPH while I was out there, University of Massachusetts. So, going to school, traveling around, just a dynamic time, to learn, to develop further leadership skills. And I remember Dr. Crabtree had to get deployed to Iraq. I think it was Iraq at the time. And he said, Scott, you got to help me out here. I'm heading over there, and you could just be acting, lead, you'd be the team lead kind of thing. So, so I'd go around and all over the place with the team. And he came back and he said, hey, doing a great job. Keep doing it. So, he had a million things to do. He was doing surgeries, and he's deploying into war, and then he's trying to be the director. And so, I started to pick up that leadership role, leading in the DoD too. So it was learning a different way to do things.
Absolutely. I could only imagine that was critical for your ideas and change that you brought to Commissioned Corps headquarters, which I want to talk about. Before I do, I'm just curious, because again, I just see this story that seems obvious as we're going through it, and then again looking at your CV. But did you get into HIV and AIDS in Gallup or New Mexico, or was that just something that you got into in Pacific Command because they needed it?
Honestly, I said, okay, now I'm about to do global health and I'm about to do HIV, and it has nothing to do with pharmacy. So, you know, this is a part of throwing yourself into that zone of discomfort. Yeah. If you're not uncomfortable, you're not pushing yourself, you know, that saying or whatever. There's many variations of that saying. And every 3 years, I pretty much felt uncomfortable in my career. And I've done it over and over and over again. And you'd think at some point, I think maybe now when I retired, I feel differently. I feel, oh, okay, it's just another discomfort, and that's fine. That's how I grow. And it is difficult and challenging as a junior officer to throw yourself into something you're completely, out of your league in your mind, right? So, and then you overcome and you learn like the matrix. I always felt like I plugged myself in the back of the head and absorb. People don't even know the matrix except now the new matrix is coming out.
Yeah, but, I love that movie. Yeah,
you plug yourself in and you absorb as much as you can possibly absorb and then adapt. So that's what I tried to do.
Yeah, I want to ask more questions about that, but I kind of want to get to some of the other stuff too. So after
you brought me on board here, Sean, so I could talk for a long time if you want.
Okay, well, I'm just curious because again, I think as a PHS officer, it does take some guts to put yourself out there, even just like walking around in the uniform. Like people are gonna be like, oh, like what are you? That's one thing. Like you're maybe at the grocery store or something. Now, if you go on a base or you're with the military, I feel like you really need to know your stuff and know how to act right. So I'm just curious, are there any stories or lessons that you learned where you're like, wow, like I they really showed me, or like I learned like a really good lesson by, I don't know, maybe if you want to share like an embarrassing story or something that you learned about officership and just, how to be an officer with others.
Well, it is amazing. The one thing that I actually maybe had some embarrassing moments, but I was trying to be squared away as possible. I think for me, the amount of respect that you get is it's overwhelming and in a good way. I mean, it's people who, it's almost like a dog, right? It's, they say, your dog loves you unconditionally. Mm-hmm. The military by rank is almost forced to respect you unconditionally. And, I've never felt like I didn't want to earn somebody's trust or respect, but by rank, you get it, even though you didn't earn it sometimes.
Yeah.
And I always felt uncomfortable with that. Right. So, I tried to really be squared away and be that presence and be that officer, not because, I was it wasn't the ego part. It was the presence, because if I'm going to command their respect, and earn their respect, they're going to give it to you one way or the other, whether they believe that they, want to do it or not. They sort of have to by protocol. And that's kind of the same thing that I took into becoming a flag officer. I mean, it's the most visible rank. That's one of those positions that some people, look at it in a way, it's like just another promotion. It's a great promotion, but I looked at it like you have to have a completely different presence and a completely different respect for that rank, because it's not just a promotion. It's not just an admiral in the U.S. Public Health Service. It's an admiral across all the services, and everybody respects you. The people who are E9s that fought in war after war after war and earned the backbone of the U.S. military, and they have to salute you at will because of protocol. And it's humbling. It's so humbling beyond belief. And so when they do that, I want to be sure that I did everything possible to be the leader that they expect me to be. And so this is one of the issues I've had with Commissioned Corps admirals, to say, you don't realize what that rank means, and you have to make sure that you have that presence and have that confidence, not ego, just confidence, because that's what they expect from you. It's not about ego. It's about what they expect from you as a leader. And so, you're an admiral or general in the armed forces. You've earned it. I'm sure. And so we want to show that we've earned it too. And you have to be that presence. So, I mean, I think maybe I didn't learn that all at Pacific Command, but it was certainly the start of it, and the camaraderie piece, which was, very important.
Yes. Yeah. Critical. I'm shaking my head here, or nodding in agreement, because I obviously haven't been in the positions you have been, but I have felt a sense of that, where take that very seriously. Because again, there are people, like you said, to the E9s that like, these guys have been in like crazy situations, and for them to salute you is very humbling. And so yeah, I take that very seriously. I always said, like, when people would talk about having to wear the uniform, that always pissed me off. And then I would always say, you get to wear that. Like,
it's a privilege, without a doubt.
Yeah,
it's a privilege every time. And I think I probably said that at 100 OBCs, well, 70 OBCs, the privilege to strap that on every morning and see that rank, and to just know that you represent everybody in uniform, your brothers and sisters in uniform, so I don't know how you can, and I miss it. I mean, I got to tell you, the civilian tie thing is just not doing it for me, but I love the and it's so confusing, because you have to actually pick out outfits every day. It's
exactly, that's what I love.
It's not the same outfit. So
exactly.
My wife has said, you're like a third grader. I have to pick out your outfit for you the night before. So yeah.
Yeah, no, I hear you there. It makes things easier. So yeah, no, this is really really good stuff. So was your assignment at DoD, was that a short-term assignment? Like, you knew it was only going to be such and such years, and then you'd have to go somewhere else, or how did that next transition work?
It was really confusing, because we wanted to keep it long. It was 3 years. I did my 3-year tour out of the Global Affairs, Office of Global Affairs, in HHS, and different change in administration, change in sort of approach to how they wanted to assign officers out to Pacific Command. Admiral Carmona, I can't remember where he was in his tour, but he used to come out and visit me in Hawaii, which was a wonderful privilege. He wanted to see his DoD colleagues, and it is a small world, by the way, and everybody, the network, I'll continue to hamper on this, but the network we have as officers is probably one of the most valuable things you get out of your career. And it is a small world. So my director at the time, Dr. Crabtree, in the Army, was actually worked with Dr. Carmona at the University of Arizona when they were going through. And I don't know if he was his attending or what, but there was a relationship between those two, and they knew each other. And so when Carmona put me out there, and they reunited, and so it was great. But small world, trust me. And when you get into the things like global health or expeditionary health, what we do now at AMI, it's a small world, right? And so the world of healthcare in general, and like what the Commission Corps does in our scope, you'll meet people from all over, and you'll keep meeting them later on in life. And so another thing you got to build bridges, never burn them. And you never know where you're going to come up with, where you're going to meet somebody again.
Yep. I'm with you there. And I love staying connected with the PHS family for sure. So definitely some high skilled individuals, to say the least. So So you got to hang out with Carmona, so to speak.
I did. We did.
So what was that? How did that affect you as an officer? I mean, he's a pretty strong personality. I'm an 04, and that was another sort of moment in my career where I wanted to, emulate what he did. And everybody remembers when he was a Surgeon General and come in the room and people would stand up and roar and stuff like that. And I thought, man, what an inspirational figure. And I hope someday I get the opportunity to do that. And if I do, I want to bring it home. I want to do the same thing. And it really, no matter what people say, it's not the feeling that, look at all these people, like so excited to see somebody come in a room, and it wasn't about that at all. It's the energy and the feeling that, like,
you can just energize and inspire so many people. It's like I said, it's probably the most rewarding thing that I've ever felt that I had the opportunity to do. Even to this day, I don't know. I do a lecture that's off the shelf kind of about infectious leadership, and I do it now in retirement, where you talk to different groups about infectious leadership, but it's that inspirational type feeling that releases the chemicals. Your neurochemistry changes when you're inspired, and that's a fact. And people are more productive when they release those chemicals, those neurotransmitters, and that's a fact. So, it's such a good feeling, and I can't even describe it really. And to have had the opportunity to do something like Carmona, not to the magnitude maybe he did, but certainly to inspire the troops was that's a privilege.
So, what do you think was? And to be honest, I'm a little ignorant to some of his accomplishments while he was Surgeon General. What were some of the things that he did that you really appreciated and respected?
Well, I mean, the main thing for me was that he changed the way that we view the Corps. The esprit de corps was his probably lasting legacy. You could talk about reports from the Surgeon General, but his relationship with the armed forces, his camaraderie with the other surgeons generals of the other armed forces. He made us a uniform service respectable with the other uniform services for what we did, what we were specialists at. And he, I think he might have been the one to say, we are sort of a specialist group of military force, right? The Marine Corps is specialized, right? They're first in, last out, kind of that sort of hoorah attitude. And our ethos with disease and public health is specialized to some degree. We're not a general force. We're a specialized force, right? So not comparing to the Marine Corps, but analogous to the fact that we're specialized in many ways. So we should be prideful of the fact that we're specialized. And we have we have a lot of depth and a lot of breadth of expertise in what we do. So much like the Marine Corps and what they do.
Yep. Okay, that makes sense.
And he brought along that sort of pride and camaraderie with the DoD, and that's how we behaved and acted, and gave us a lot of respect as a service. Okay,
good to know. Yeah, he's another officer that I really need to research more about. Obviously, I'd heard of him and know a little bit of him. So, and Scott, I just want to check in. Are we good on time? Or
absolutely.
Okay.
Why not? This is what I love to do: talk about the Corps and some of the things that are so great about the Corps and what we've done and what we can do.
Okay, appreciate that. Thank you. Okay, so you left Pacific Command, and then your next stop was Indian Health Service headquarters, I believe.
Yeah.
And you were then in charge of the National HIV/AIDS program. Indian Health Service is really hard. I think a lot of people don't know that. And again, to some of our points we were discussing before, like I think you get so many strengths and skills from being in IHS. So from your perspective as a leader, you've seen a lot of stuff. Like, what are the biggest challenges in IHS, and what did you see as some of your big wins being with IHS, and where do you think it should go?
Well, the biggest challenge is exactly why we serve them. They're underserved and vulnerable population, right? So that is their biggest challenge. I mean, it's the resources and the unfortunate history of the population. And yes, the government it's a double-edged sword for the government sort of has a responsibility to American Indian Alaska Natives, and yet you want to see them succeed, proliferate, integrate, assimilate, all the different things that you see some of these successful tribes that have maintained their traditions, and yet their tribal entities have been successful. They've managed things well. Their own healthcare units, the 638 is what we say, and when they take over, and you see that success is wonderful. But then you see the other side of the coin, where there's some of the poorest counties in the country are, densely American Indian Alaska Native populated, right? South Dakota, some of the reservations in South Dakota.
Yep.
So it's difficult sometimes, but the bottom line, vulnerable, underserved. We do what we can do in the Indian Health Service, but it's not the final solution or final answer. I think one of the wins, or some of the wins I had there, it's more like what I learned. What I learned, in each of my jobs was something different. And for this one, which was helpful for me for my entire career, especially in leadership, was cultural fluency on steroids. To learn how to be culturally competent and culturally fluent is what I call it. It's sort of on the spectrum of cultural ignorance, cultural awareness, cultural competence, cultural fluency. And that's like the highest, level to get to a point. And I can't claim to be culturally fluent, but what you learn to get closer to that point, American Indian, Alaska Native, Indian Health Service, that's what a proving ground, if you can make it there. And so as the National HIV/AIDS the director of the program, most have been American Indian, Alaska Native, and I wasn't a physician, and usually it's a physician to run that too. So it's another thing that I sort of had this, I cracked some of the multidisciplinary positions that weren't previously anything but physicians, right? So, but to be in that role was really a leadership role. You had to have medical background or public health background, but really it's being a leader and leading the program, and that in that environment of cultural, and the need to be culturally fluent. So then when I say on steroids, you have the cultural fluency of being American Indian, Alaska Native environment and population. Then you throw the HIV/AIDS in there with all the stigmatization, with all the sensitivities around that. At the time, LGBT, those issues, and for me to get, sort of catapulted in from, think about it, DOD, right? You go DOD, global health, which there was a lot of similarities with indigenous populations abroad, into HIV/AIDS, American Indian, Alaska Native. So just a whole nother skill set that I had to have, and try to develop diplomacy and how am I going to relate to succeed in an environment where here comes a military white guy in uniform, trying to than he's normally used to, right? So that was a challenge, but boy, I loved it. One of those things I'd go back in a heartbeat and redo. Don't regret a bit, not a minute.
Yeah.
So many wonderful people I met, taught me so much about a lot of those things I just mentioned. So just tremendous experience. Tried to help the population, tried to have some wins as far as program metrics, programmatic metrics and succeed milestones. And then that was it. And then it was my transition into headquarters.
Yeah. So this is the fun part. So at this point, I would imagine, now we're talking around 2011 or so. And so you actually had you're wearing two hats. Were you the CPO and HQ director?
Correct.
Okay.
I started in 2010 as CPO. Okay. And between 2010 and 2014, which is the 4-year term, I went into headquarters as the director.
Okay. Now, when you were at IHS, working with the HIV and AIDS program, is CPO, CCHQ director, they didn't call it that back then, I think it was DCCPR. Were those things on your radar? Were you kind of gunning for it? What was your mindset at that point? Were you just going on the adventure?
Well, the CPO, I was interested in, obviously, because of Indian Health Service, coming from there as a pharmacist. CPO is a great position to advocate for the profession. So yeah, I definitely wanted that leadership role. And that, once again, let me just real quick jump to that. The CPO thing was leadership and soft skills, because there was no chain of command in CPO. You had no authority really to do much as CPO other than to lead and advocate by soft skills, right? Influence and advocacy. And people didn't have to follow you if they didn't want to. It's not like was a little different than it is now too. And some of the CPOs have a lot of sort of duties and responsibilities that we didn't have as much. And you really had to lead without that chain of command or authority over folks. And so that was wonderful. And that was probably even better than leading when you do have a chain of command, because then you have responsibility for other things and management.
Yeah.
But yeah, it was wild and fun. So, but yeah, back to the transition. Yeah, and I was asked. Admiral Lushniak at the time and Admiral Halliday, who was the chief of staff, came to me and said, "We really need you at headquarters." And well, it was DCCPR. It was actually not quite DCCPR yet, but it was almost DCCPR. And they said, "You want to come in?" So.
Okay, so it turned into DCCPR once you got in there.
Yeah, there was a Federal Register notice, and we had to take different pieces, all these different pieces of the Corps, and amalgamate them together in DCCPR, but which is really its headquarters is.
Okay.
It was just not called that because that was one of the things that I can definitely say that before it was headquarters, Commission Corps headquarters. We put it into the language and coined it, and then put it into the Federal Register notice. But the subsequent director was the first director of headquarters, which is Susan Arcega. Susan Arcega.
Yep. Okay. So when you got into headquarters, what surprises did you encounter? Kind of peeking behind the curtain, were you like, "Whoa, I did not expect to see that"?
Let me just say this: in my entire career, it was the hardest, by far, the hardest position I've ever held. It is even, far harder than the subsequent position that I had as the acting DSG for a long time. And the only reason I wasn't permanent, Admiral Lushniak's acting, I was acting, but it was like permanent. When you do it for almost 2 years, it's kind of permanent, right? So,
yeah.
But it was the hardest job. It was just there's so many complexities of running a uniform service in general. Now that I'm retired, I can say when you were under-resourced, at the time, it was a group of folks that were not supportive of the Corps.
Okay.
A lot of the political appointees at the time are not supportive, actively trying to not let us succeed. And which is ironic because it was one of our finest moments during Ebola, to come through with the shining. So it was a constant battle. Which went behind the scenes, because what we tried to project was what we did, just the inspiration, with Admiral Lushniak, and it was a phenomenal partnership I had with him. And it was so, to feel the Corps' energy, even amidst all the challenges and amidst the fact that they were once again trying to get rid of the Corps, all during our term of succeeding. So, at such a high level and such visibility. And meanwhile, behind the curtains, they're trying to smash you with a sledgehammer, So it was that level of disconnect that made it so very difficult and challenging as a role. And then just take headquarters in phenomenal times and support. It's still very, very, very difficult because it's such a complex uniform service to run. We don't have a centralized budget. We have 18 different departments and government entities we assign officers to, and you have to have all these different partnerships, all these issues, deployment, policy. If you think about all those different things in another uniform service with support, it would be difficult. And so the bond we developed, Admiral Lushniak, myself, Dan Beck at the time, and everybody that was at headquarters at the time, Greg Davis, who's now Admiral Davis, Angela Matungwa. Just so many people. Scott Helgeson. You bond, and then the unit after us, the leadership unit after us, bonded the way they bonded. Admiral Trent Adams and Susan Arcega and Admiral Hunter. Because you go through that, I'll tell you, there's nothing like it, right? So,
so were there any, I mean, I know a lot of people have received numerous criticisms about the Corps or know about those from whether it's OMB or just other sources. What were some of the things that you were getting that you had to swat away and defend and kind of keep under control to keep the ship going?
And age-old arguments, I mean, we're just like civilians, the typical, we don't do anything different. Although, we started deploying nonstop since Ebola, so, I mean, but we always had, since 9/11, we've been deploying nonstop. And, you don't know much about the Corps until you're in need. And then when we step up, the Corps is great. And then the second later, they forget the Corps is there and needs support, needs, funding, and needs appropriated line item funding, because it's hard to advocate and for us. We don't have lobbyists. We're a little hampered in a way the DoD isn't. And so we have to hope that the secretary and those political appointees that come in will support us, or you're in a very tight situation because you're buried in the org chart of the department.
Exactly.
You can be made very invisible, or you can be made very visible, So much like Admiral Dubois just did, very visible out front with the president during this administration, or the previous administration. So
it
doesn't matter what administration, doesn't matter Democrat or Republican, the service should and does transcend all, right? It's about health, not about the politics.
Yep. Amen. So to me, if I could wave a magic wand, I would want force management and more of a centralized structure for the Corps. Do you think that's necessary, or do you think that would be beneficial? How hard? To me, it seems like it would take an act of Congress to get that done, literally.
Oh, yeah, absolutely. It does take
just a restructuring of our service. Do you see that as a force management as a real barrier, or is that a distraction?
It's really hard in the construct that we have now, where we're assigned to agencies and the agencies pay for our salaries. It's almost an impossibility. Ideally, essentially managed budget, but ideally, if you think about, and I've tried to think this through a million times, and to be more back in the the way that it was structured originally, where the Surgeon General was more right under the Secretary and it wasn't buried so deeply. To have commissioned officers be the heads of agencies like the NIH and the FDA, and it would be a lot different situation. But assigning officers to each individual agency and then having them pay for us makes it a very, very difficult construct to work within. So ideally, yes, maybe centralized budget, but we'd have to rework the rubric of how we operate and who we report to. And, we could be the Secretary's uniform service, much like Secretary of Defense has all the armed forces, and the Secretary of Homeland Security has the Coast Guard, and the Secretary of HHS has the Commissioned Corps, but we're buried pretty deep. We actually and factually belong to a policy office, which is OASH, right? Office of the Assistant Secretary for Health. So that's not necessarily the way we operate or deploy or act. But,
I never thought about it that way. Okay.
It's kind of an odd matching. And so that's a little bit different as well.
Okay.
So anyway, there's a lot of things I would wave the wand at, but, think about if you could, we have the mandate to do public health and response in anywhere in the world, and it could be wielded by the Secretary. And if a Secretary came in and said, oh my goodness, I'm one of 4 secretaries that have a uniform service in the entire US government, right? If you think about all the departments where there's a uniform service, whether it's any of the armed forces, and us and Coast Guard, NOAA, everybody, it's 4 secretaries, that's it. And if you came in knowing, wait, I get a uniform service too, that's amazing, right? And I could embrace it. Tommy Thompson was a little bit more like that. Thinking about, and I'm not picking, trust me, I have become very apolitical when it comes to what party I'm talking about. I don't even remember some of the folks I worked with, but it's just about how they utilize the core, and utilizing the core for Ebola was a phenomenal difference in wielding us for global health, and because we had the mandate to do so, because nobody did. And that's amazing, right? The DoD has a warfighting capacity and humanitarian assistance, but it couldn't actually touch and care for patients overseas. It wasn't in their SOFA agreement. It wasn't in their bilateral. They didn't have bilaterals, but HHS was able to get us to be able to do direct patient care in another country. So we were the only ones. We were the only ones that could do that. And so, by statute, we can do things that other entities can't do. And new political appointees aren't familiar enough with how to use the core in a way that would make their administration look phenomenal, right? So I don't care which administration.
Interesting.
And that's one of the things we kept trying to push and to use this. And that was in the story of how we got into Ebola was a matter of convincing the secretary that we are by statute allowed to do this.
Yeah, so I would love to hear that story. That was actually one of my questions is, because there are these public health crises, humanitarian crises that pop up, and sometimes the Corps is involved, sometimes they're not. So I was curious with Ebola, how did the Corps get involved? You mentioned a SOFA agreement, some stuff by statute that we could do, but the armed forces couldn't do. So could you talk a little bit about that story and how we got involved?
Well, so in our statute, and boy, I'm not really deep. See if I could think of this one. It's 42 USC 204A potentially. It might be that or 2. I can't remember exactly, but we talked about that statute, and it was for public health response or disaster response, both foreign and domestic. And that little phrase there, both foreign and domestic, made it allowable for us to do that. And we had to sort of go through the Secretary's counsel, which is the lawyers, and say, look, read this. That she, at the time of Sebelius, can deploy us, right, for Ebola. But before all that, I tell you how we got involved. We got involved because we have Commissioned Corps officers in every agency. CDC was already there, right, before the big Ebola outbreak in West Africa. The CDC was investigating. And guess who was investigating? Corps officers. It was tabbed as CDC, but who was it in CDC that was doing it? It was Corps officers, right? EIS officers or deployable Corps officers. As we got more towards working with the U.S. government and State Department, they involved one of my colleagues at the time, who's Captain Mike Schmoyer now, Admiral Mike Schmoyer, right? And he was working, and I think he was with either Office of Global Affairs. I think he was with Office of Global Affairs at the time, but he told the National Security Council, hey, you guys know we have a Commissioned Corps that can do this. And it sort of stimulated the questioning to CDC, hey, this Commissioned Corps can do this. And then the CDC guy, who's Commissioned Corps officer, said, look at the headquarters of Commissioned Corps and start to ask them about, can they do this, and talk to the Surgeon General. At the time, the Surgeon General was Admiral Lushniak,
yep.
the SG. So they came to us, and the Secretary called Admiral Lushniak, and Admiral Lushniak turned to us and talked to myself and Dan Beck at the time, and his chief of staff. And, think about it, the most deadly disease probably on the planet, or one of them. We have zero training in Ebola, right? And the decision comes down without training, and something the DoD is not going to do. We're going to deploy to a foreign country in a very austere environment in hot zones and take care of Ebola patients. It took maybe 5 seconds for us to say, yep, let's do it. Admiral Lushniak said, call the secretary. I can't remember where the final call was, at his home, whatever. He said, man, let's do this, right? So, and I don't know his exact words, I'm paraphrasing, but the bottom line, how Admiral Lushniak is, he's like, we can do it. He probably put his hands up. We can do it.
Yeah.
So anyway, and there we were off. And he said, I don't think he had to actually ask. I was probably pounding on his door to allow me to help lead it. And he said, yeah, do it, lead it. So
wow.
That's how that happened. And yeah.
Thank you for Like, yeah. It just seems
but
like
you
all
got to
the
remember
people.
that network, that was the network. It was Admiral Jordan Tapero at the time, and it was Mike Schmoyer at the time, who was the captain, and it was, Admiral Lushniak, myself, actually going over and doing that. But three different entities, three different agencies in the U.S. government, all with commissioned officer leads, that made it happen. It wasn't just within OASH or just within, because it probably wouldn't have happened if it was like that.
Okay, yeah. So Ebola, my history is a little fuzzy, but I believe it was from 2014 to 2015. It was really going on. And
yeah, the heaviest time was probably late summer, early fall of 2014.
Okay. And a lot of people that were getting infected were actually, so to your point, it was super deadly. I think it was like 40 or 50% fatality rate, higher.
Oh yeah. Oh yeah, way higher.
Okay.
Yeah, it was probably more like 80% fatal at the time. If you get Ebola, yeah, it's not like COVID. Mm-hmm. It's very lethal, very, very lethal.
Wow. And so, and my understanding is there's a lot of their healthcare workers like that they really needed to take care of their population were contracting it too, and that was the mission. But please correct me if I'm wrong. But that was kind of the mission, was to go and make sure those people can actually stay well and take care of the people that were getting sick.
Right. So we went round and round the National Security Council, President, White House. What could we do? I mean, we're not a huge force, right? We're not coming in the tens of thousands like military. But what we could do was, or what would be our best impact would be to take care of healthcare workers that became ill. So our clinic was specifically or our Ebola treatment unit was specifically for healthcare workers and sort of ancillary health related folks. But the key wasn't the amount of folks we saw, because, honestly, we didn't see a ton of, we did have, tens of Ebola patients, but not hundreds or thousands. And some of the other clinics were much bigger, and they were seeing nationals, Liberian nationals or Sierra Leone nationals. But the difference was, and this is the what turned the tide or helped turn the tide of Ebola, was once we set up other healthcare clinics, other healthcare providers, we had an influx of over 1,000 primary care folks come to Liberia and the three, Liberia, Sierra Leone, and Guinea, after we set up our clinic. So I think we opened first week of November, and the first week of December, we had the three countries had an influx of a lot of healthcare providers, because they felt like, okay, well, if I do get Ebola, the American ETU is there, and we can get seen in a fairly decent Western style medicine kind of thing. So that's
so it gave confidence for them to come in to. Okay.
And I don't know who said it changed the tide, but it definitely. Yeah, I remember getting interviewed, and I said it was sort of a beacon. It was sort of a beacon for other countries to send their healthcare providers to say, it's okay, you can do it. We're here, we're doing it.
Yep.
You can do it, and we're here for you. So,
so how did the partnership with, because I believe it was the Air Force that you guys worked with that set up the hospital. How did that, or was it not?
I mean, there was multiple folks, the CBs, Air Force, I think McGuire Air Force Base had a pallet of some of the, sort of off, the sort of Alaska tents and shelters and sort of to build. But it wasn't just the Air Force that was building. We had Army, we had 101st Airborne, we had, I can't remember some of the other units that were there, but they all sort of chipped in to help build the entire, sort of ETU and the grounds around it. They provided security. We had some marine contingent that was helping us with security, because it was a pretty stressful environment, and you never knew what was going to happen. There's always the nationals that believe it's a conspiracy, or the Americans are bringing Ebola to Africa, the typical sort of thing, which isn't unusual. It's just the way it goes. But so yeah, we work very closely with the DoD to build it. and then we staffed it and managed it, try to make it work. And luckily it did. But I got to give credit to the hundreds of I think we had 400 maybe. We had almost 1,000 people deployed, but 400 in the hot zone, in Ebola, in Africa, with the most deadly disease on the planet almost. And it's to think that they did that without real training for it. Of course, nobody had any Ebola care, but except for some NGOs that had been doing it. Wow. And I remember this, we didn't, back when it was deployment like that, we needed to know who would go. And we can deploy, without asking. But this was such an unusual situation. We wanted to get sort of a sense of who is ready to do this. And we asked who would be ready. And within 3 days, we got 5,000 responses. There's only 6,700 Corps officers, and 5,000 immediately said they would go. I mean, that's unbridled volunteerism.
Yeah.
So
I mean, that's exactly speaks to the underutilization of the PHS as a whole. Yep. Like, you have people that, okay, criticize all you want, like maybe they're not moving as much or going where they're needed sometimes, but they would, like, I feel like it's just an untapped resource where it's like, these guys are ready to go. They're super high level, heavy trained.
You think about it in our world, right? If you're talking to a Marine and you're saying, hey, would you just get dropped off into battle? And they would be like, hell yeah. Right. Because that's what they do. Right. And they're lauded for their courage. Right. Because that's courage under fire. It's amazing. They're fearless. Right. You think about 5,000 officers going to the most deadly disease on the planet without training. That's like saying, okay, here, Marine, here's your gun, but we're not going to train you. That's what they train all the time to go fight in war. Right. Mm-hmm. We are not trained to do what we volunteered to do. So that was true courage for those folks, for the people that deployed. I had a nurse that was maybe 6 months out of school, and she got commissioned, and then she got sent to Liberia in the hot zone. I mean, you gotta be kidding me, right? So kudos. And you can't say enough about the courage of those people, our people, that did that. And when we were over there, I was right next to the Marines, and the Marines were providing security, fearless. But when it came to the Ebola, they were very uncomfortable with the fact that we were in the hot zone, and that was an enemy that cannot be seen, shot at, touched. So it's a very different kind of courage, right? So
exactly, they were
very proud of us, and they gave us a tremendous amount of respect for what we were doing, as we would always give them respect for what they do. So
absolutely, yeah, it's totally different game on both sides. And I just want to share with you really quickly a quote that I always reference about, or it came from a PHS officer, Milton Rosenow, I believe is his name. And he has a quote that goes to the effect of, while not as glorious as taking a bullet in the battlefield, the doctor's mission while in the field, and he's like studying like Rocky Mountain spotted fever, like all this, these crazy unknown microbes, like in the early 1900s. He doesn't, but he has a really great quote about, like, it's not as like glorious as like going into battle, like taking bullets, but bacteria are deadly as bullets and invisible. So I always think about that quote and share that with people.
Great. Fantastic quote. Yeah.
So I want to be respectful of your time. We're coming up on 2 hours here almost, but I got to know, what was it like to speak with President Obama? And and again, like, you, and I know there's other people involved in this, but you earned PHS the first presidential unit citation. We got another one for COVID, but just what was it like meeting President Obama and just being in that situation?
Well, obviously honor. Our relationship actually started, and I say relationship because I'd met him like 3 times now, but when I was in Liberia, and they said that, and I know that it was, I think, our Assistant Secretary for Health at the time was close with the administration, and he said, who do I need to talk to, or who do I need to connect with, and they gave my name. And so the White House called my cell phone over in Africa and said, on Tuesday, you're going to get a call from the president. And I said, my first response was, what president? Because I was thinking it was President Sirleaf Johnson, who I did have a lot of interactions with, and she was the president of Liberia. So I thought very logically, oh, President Liberia is going to, and they said, no, the United States president. I said, who is this? I thought it was probably one of our officers playing a joke on me or something, but sure enough, it was the White House. And on Tuesday, at 10 of 2, they got a call. The White House called the cell phone and said, is this Scott? Yeah. How's the connection? Good. Can you hear me? Good. And I was in an air controlled, Alaska tent that was connected to the hot zone. It was a green zone, but it was, we had to turn the generators down a little bit so I could hear. And the team was in the other tent just to, hear what was going to happen. And they said, this is the White House standby for the president. And it was silent. And then right before 2:00, the gentleman said, the president of the United States. And then the first things he said, I think, was, hey, Scott, how's it going? And so, I think we had I did tape it. Believe me, I taped the conversation. I still have it on one of my laptops or my hard drives. It's I think it's about 8.5 minutes worth of discussion with President Obama. And look, I don't care what president you voted for. Talking to a president like that is
absolutely,
an honor. And really, I was thinking about, boy, the Corps speaking to President Obama, not me, but what we're doing, what the team is doing, not me. I just happen to get to be the lead, right? So, that was the first time. And then the second and third, just different venues where we were at together. I had to introduce them at one, and then the other when we were in the Oval Office getting the puck. And so, that was obviously, another set of honors that was great for the Corps. So,
absolutely.
Yeah.
Thank you so much.
Hey, I'll tell you what, I've spoken in front of so many venues, thousands of people. I've done, commencements and, talks at annual symposiums, and fearless, no problem, love speaking, love getting around. Admiral Lushniak and I were always up on stage doing some goofy thing, never was nervous in my life, and always actually wanted to be in the speaking role in front of a crowd. And for the first time ever, I had to deal with a little bit of stage nervousness, and I couldn't figure out why my one knee was shaking, and because President Obama was standing right next to the podium, looking over my shoulder, literally probably a foot away from me, and I was trying to read the script and remember, I had memorized it, but I was trying to say it, and
yep.
Yeah, that's a little different. So I figure if I can handle that, I'll be all right in normal speaking environments.
Yeah, that's a high bar.
But now I know what other people feel like when the president's standing right by you. If they have a little, mistake in their speak, I can totally understand why.
Absolutely. I have 2 more things I gotta ask you about if I can be selfish here. So again, I just want to thank you for all your work with the Monrovia Medical Unit, and again, I see that as a symbol of what PHS should be doing all the time. And again, just thank you for your service with that mission.
But just remember, though, it was 1,000 people that did it, and
yeah,
leadership came from many different ways, and so yeah, it was a huge service core level effort.
Absolutely. So you were exiting the Corps, you're about to retire, and then we have this thing called COVID hit.
Mm-hmm.
So I'm just thinking, did you have any involvement? Were you, because I'm thinking, how could PHS have gotten involved in a fashion similar to Ebola, but this is obviously on a worldwide setting. Right. So just what's your perspective of how we've handled things? Did PHS step up the way it needed to? What was missing, if anything? I just would love to hear what you think.
Well, yeah, I mean, every response is different.
Yeah,
I think Admiral Jawah handled it admirably, if I may say so. He represented the Corps in uniform. I think the difference partly was that everybody was involved in COVID.
Yep.
every doctor, every nurse, every healthcare provider, pharmacist, whatever. Ebola had the different dynamic of, you know, we were very unique in what we did in our role, and we were the only ones that could do some of the things we did. So it was a little bit more defined. And in this way, I don't think it was wrong the way anybody handled it. I think that we missed some opportunity to recognize the Corps as an entity in and of itself, as a service, versus there were so many of us doing so many things in COVID, right? And Admiral Joao leading it, obviously in uniform up in front of the, it almost got lost in the shuffle because so much was going on with COVID, and the whole world was, you know, doing some piece of it. But he did a great job representing us. And of course, and people forget Dr. Fauci was a commissioned officer. People forget, I mean, you know, that's never been mentioned. I mean, you know,
exactly.
There's so many people that were involved that were commissioned Corps, and that's the one thing that hurts us all the time, because I don't know if he would identify as that, but I would. Exactly. I mean, I knew he was a great officer, but if I were to ever come back in a civilian role, and suppose in the future Ebola hits again and they use me as some sort of a course, you know, consultant on, you know, wherever, Malushniak on NBC, guarantee you that, you know, our time in the Corps would be coming up a lot.
It would say, you know, it's going to say Rear Admiral retired Scott Giberson.
Yeah. Yeah. And that's the little things you had to make, you know, one of my responsibilities with the Corps, with the Ebola response was, in my mind, was to embrace that visibility and the opportunity to, and it's not exploiting it to promote the Corps. It's to say, this is a tool, a resource for the government to use, and to, you know, when you can, this is exactly how you should use this. And then one of the things about the Ebola response too, and I forgot to mention, this is the first time we really didn't fall under the DOD in a response effort. So when we're part of Operation this or Operation Freedom or Operation, you know, whatever it is, we did not want to be part of that, because we wanted to be our own service with our own unique capacity to do what we did. And so instead of not being at the table because we were under DOD command, we sat at the table next to DOD, and that was a huge difference in the way we did it.
Yeah,
and that's helped with visibility. But so in this case, I think that like I said, everybody was involved, so that's sort of a little bit harder to be as visible. But then just to recognize us as an entity specifically, Admiral Joao was able to do it. But as a Corps, we were so diluted with all this other stuff that had to be done with COVID, it was a little harder.
Yep, exactly. And I love that you brought up Fauci, because yes, he is indeed a Corps officer. And he was part of the so-called Yellow Berets. And there's interesting history with that. And it used to be used pejoratively, that term, but I actually read a really good article that I should share with you, where a lot of the guys that came out of that are all Nobel Peace Prize winners. Yep. But so this brings me to the next and final question that we can kind of end on. It has to do with the uniform, and I want to tie it into with the Surgeon General. So the guys, the Yellow Beret guys, they didn't wear the uniform. They weren't necessarily proud of that, and that could have been because of the culture at the time with Vietnam. Does it matter that I know I have my answer to this, but does it matter that PHS is in uniform? That's my first question for you.
Yeah, the answer is 100% yes. I mean, in my eyes, the fact that we're in uniform it separates us from a number of ways. One, commitment. You are in uniform, you commit to things that other people don't have to commit to. Okay. There was this, one of the OBCs I did I think the OBC was on Veterans Day, and there was an essay written by this young woman, like a real young woman. I think she was in middle school maybe. And it said, should everybody join a service, in the United States for at least 2 years, right? So force everybody to do that, right? And at first I thought, oh, heck yeah, nationalism, esprit de corps, everybody should understand what it feels like to serve. But then I thought about it, and it was a little bit different, because I think the people who join the Corps commit to it because they're passionate about it and because they want to be in uniform. So, I don't want somebody who doesn't want to be in uniform, right? I don't want somebody who doesn't want to commit to sacrifice, to do things differently. It's not the easiest. Like, yeah, we want you to deploy a lot, and yeah, we want you to go to different places in the United States and work for the Indian Health Service or work underserved populations, Bureau of Prisons, you know, ICE Health Service, Corps detention centers, you know, whatever. It's not the easiest path, but that's why you commit, and that's why you put the uniform on, to say, hey, look, I'm committed. Here it is. Here's a meritocracy that I got to prove myself to get up in the ranks. It's going to take time. I know that. And you know what? I'm not going to get paid as some of my colleagues in the private sector. But it is such a prideful thing. So yeah, absolutely. Absolutely. If not, we'd be much too similar to a civilian. And even DOD suffers from that same, you know, they're outsourcing so many things that the DOD used to do, you know, healthcare in general, they're outsourcing more, you know, so Coast Guard, DOD, DHA, you know, all those things. So yeah, 100% in uniform.
I'm with you there. Okay. Last question. And so you said earning rank, you just said, you know, go through the ranks. Does it matter? And again, Lushniak was, again, even me coming in pretty, you know, towards the end of his career, I remember seeing him speaking, and I know the sense in the Corps at that time was everybody wanted him to remain Surgeon General. He was acting for a little bit. He's a great leader. He's from the ranks, right? Does it matter that the Surgeon General comes from the ranks?
There's two answers for that. It's yes and no. Admiral Lushniak will be the first to tell you the same thing that I'm about to tell you. Having been there and done that, there's certainly the piece that you'll hear Admiral Carmona talk a lot about. Absolutely should come from the Corps, right? The Surgeon General should be promoted from within, from the Corps. And that's, in days past, that is the way it used to be long ago, right? And that is a wonderful sense of both pride, both accomplishment, meritocracy, right? You've earned it. You're the best of the best, right? And a physician, though, and you get to be placed as a Surgeon General. So I think there's incredible value in that, from a understanding the government, understanding all the different dynamics of government agencies, which is very, very hard for a political appointee to pick up on sometimes. Understanding the uniform service, and you know, sometimes you get people who are very squared away in uniform, and sometimes you have to really do a lot of education and help them out with it. And it just depends. That's the pros of coming from within the Corps, right? That depth and breadth of experience and understanding of government and how it works. But the one thing that we lacked, and like I said, we'd both be the first to admit, the connectivity to the White House. And if you really want to push advocacy and to change things, having a direct tie to the president or the White House is a huge tool that you have as a Surgeon General. And if you don't have that connection, it's very tough sometimes, right? It hampers you politically, and everybody knows that health and politics, even more so than ever now, are intertwined. So yeah, I mean, there's pros and cons. Ideally, you'd be a person from the ranks that has the direct connection to the White House. That's hard.
That's how it used to be. You know, World War II, all the good old days. So I think about this a lot. It bothers me a lot. And would it make sense? I just want to bounce this idea off you. Would it make sense for the Surgeon General to not wear the uniform out of respect of the uniform service itself? Obviously, you'd be losing the visibility of the uniform, but and in some ways, I would want the person to say, you know what, I actually really respect this service, and I understand I'm not coming from it. And again, like rank really matters. You know, medals, ribbons, like those things, like. So I don't know. What do you think about that?
I don't know if that's happened, but I definitely would respect that if somebody chose to do that. Mm-hmm. I think now we get into the situation where, look at you never know when it could be to the advantage of the Corps as a service versus not. I mean, you know, different Surgeons Generals and different now Assistant Secretaries for Health started, you know, as with Jawad, when we wore the uniform, and we've had others. Yep. Admiral Agwanobi, you know, there's different Surgeon Generals and Assistant Surgeon Generals in the past ASHs in the past, Secretaries for Health in the past, but it just depends on the personality and you know, I guess the option is there. If somebody, I would respect somebody who said, well, I don't feel comfortable in this role, and I don't know if I'd represent well enough, so I don't really want to use the uniform. But it is a visibility piece, and it could help promote the Corps. So it's a tough question. I mean, sometimes we love the fact that they would wear. If Admiral Carmona didn't wear it, who knows? Admiral Jawad, yeah. So I mean, there's in the past and present a lot of value to it, and in some ways it's hard if you get somebody who doesn't really look or look like they have pride in it. I don't mean physical look. I mean look like they have pride in the uniform, or they don't carry it like they should as that high of a ranking of an officer, that presence that I'm talking about. Then sometimes it detracts from the uniform, and we get the rumors that start about it. So it's interesting question, but
yeah, it's a tough one. So I'm glad to hear your insight on it.
Yeah.
Well, this has been a huge treat.
Thanks.
Hopefully you found value in it, and
it's great.
Maybe it was cathartic for you.
It is. It really is. Boy, I'll tell you, this is a good evening. Normally I'm pretty just exhausted from work and watching something useless on the television or Netflix. Yeah. Right, I was watching Hot Zone on Netflix the other night. That series. Now it's Anthrax this season, but I always look at that, and it brings you back to certain things, although embellished for TV or sensationalized for TV, but you can relate to some of the things. So
absolutely. Well, Admiral Giberson, I really appreciate this, and I in some ways just feel I don't know what to say. Just thank you for all your work. And again, if anybody looks at what you've done, I just very thankful for what you've done for the public health service, which I hold dear to my heart. And it's been really good. So I appreciate it.
Well, I of course appreciate it too. Just want to tell everybody out there, that I got to serve, had the privilege to serve with, and we've been through so much as a Corps, and we've endured for so long, since 1889. I have confidence that we'll continue to endure. We'll continue to be at the crux of the public health of the nation. And we have so many good people in the Corps that we will prevail no matter what. So we'll have to adapt. We'll have to be flexible. We'll have to change again and again and again. But I think we're on the right track, and I think we'll be there for another 100 years.
Thank you.
Thanks. Appreciate the time.